حاب يكون جميعا. بسم الله الرحمن الرحيم. We are very delighted in the ISAB to host this week the team from Ireland, Dr.Ali Abdullah, she will be the moderator, Dr. Ibrahim Dafalla and Dr.Ali Eltoum, they will present one very interesting case, and we look forward for the presentation for the Ireland group. Welcome. It's yours now, Dr. Ala.
Good evening, everyone, and welcome to the International Sudanese Academic Pediatrician Platform Weekly Meeting. Thank you for joining us from Ireland, Sudan, Saudi Arabia, Emirates, and Oman, and everywhere around the world. Before I start, I would like to remind everyone that this session is recorded. The recording will be made available on the YouTube channel for those who wish to review the presentation or to share it with their colleagues. Also, there will be live YouTube channel link for those who can join through the Zoom. Today's presentation is titled, A Child with Abdominal Pain, Thinking Beyond the Abdomen. It's now my great pleasure to introduce our speaker, Dr. Ali Eltoum. Dr. Ali is a pediatric higher specialty trainee and MRCPI holder. He has served as an RCSI tutor for medical students at Cavan General Hospital between 2023 to 2024 and a formal neonatal resuscitation program instructor at the Rotunda Hospital. Most of his clinical experience has been in neonatology, and he has a particular future interest in neonatal cardiology. He also presented his works at the Irish Pediatric Association meeting, reflecting his commitment to both clinical excellence and academic development. We are delighted to have him with us this evening to share his insight on this important topic. Please join me in welcoming Dr. Ali Eltoum. Dr. Ali, the floor is yours.
Thank you very much, Dr. Ala, for the nice introduction. So, good evening, everyone, and I would like today to present a case that highlights the importance of considering extra-abdominal causes when evaluating abdominal pain in children. So, this case is about a patient who's 10 years old, previously well child, presented to the emergency department with one-day history of fever, vomiting, and mild abdominal pain. The child appeared clinically stable, and urine microscopy was done, and that was unremarkable. Based on the presentation, the child was discharged home with a presumed diagnosis of viral gastroenteritis. At this stage, what would be your differential diagnosis? And would you be comfortable with the diagnosis of viral gastroenteritis? Or are there any red flags that would make you think an alternative diagnosis other than gastroenteritis? Please feel free to put your answer in the chat box, and we'll have a look at it and reflect back.
We have one answer, pneumonia. Second answer, AGE, acute gastroenteritis.
Yeah.
Second vote for pneumonia.
Yeah, sound good. Yeah, so pneumonia can present with... yeah, great.
Yes.
Yeah, so thank you very much, Dr. Ala. So 3 days later, this child returned to the emergency department significantly more unwell, and there was severe abdominal pain, persistent vomiting, fever, and malaise. The patient's assessment revealed cold peripheries, persistent tachycardia despite temperature control and pain management, and borderline low blood pressure. The child had difficult intravenous access, and of note, this child was seen in the emergency department and hasn't yet been seen by the pediatric doctor. The initial investigations of this child showed mild leukocytosis and only modestly elevated inflammatory markers with mild hyponatremia and hyperkalemia. And the most striking feature on the investigations are the acute kidney injury represented by high creatinine and urea, and transaminitis with high ALT 5 times the upper limit of normal and high gamma GT. This child had a chest X-ray demonstrated bilateral patchy infiltrates without a clear focal consolidation. Because of the abdominal findings, the surgical team was consulted, and the child had generalized abdominal pain. On surgical assessment, the impression was generalized abdominal pain and guarding, and accordingly an ultrasound was performed, and that showed free fluid within the abdomen and edema around the gallbladder, while the appendix was not visualized. As part of the management of the child received fluid resuscitation in the form of 2 boluses of normal saline and started on intravenous augmentin. And given the concern for severe abdominal pain and guarding, the decision was made to proceed for surgical appendectomy. So laparoscopic appendectomy was performed, and surprisingly the appendix appeared normal, and the only findings were mesenteric adenitis and hepatomegaly. No other source of surgical pathology or intra-abdominal bleeding was identified. Importantly, during the procedure, the patient developed bradycardia and ECG changes, including ST segment changes, and required fluid bolus intraoperatively and 1 dose of atropine. So following the surgery, despite the child being on fluid and despite the fluid management in the form of boluses, the blood pressure continued to fall after surgery, and 3 hours post-operatively, the pediatric team was called because of persistent hypotension and tachycardia. And of note, this was the first encounter of the pediatric team with this patient. At this stage, in a patient who is hypotensive post-appendectomy in a context of recent viral infection, and that's your first time to see a patient as a pediatric doctor, how would you approach this patient, history-wise, exam-wise, and assessment and resuscitation-wise? And what would jump into your mind as a pediatric doctor in terms of causes and differential diagnosis? Would you mind please put your answer in the chat box?
We are getting through a few answers for diagnosis: adrenal insufficiency, adrenal crisis, myocarditis, multisystem inflammatory process, adrenal problems.
Excellent. Yes, absolutely. All of them can be the possibility in the differential diagnosis. Thank you very much. So the child, when was assessed by the pediatric doctor, the child was hypotensive with delayed capillary fill time and marked tachycardia. An examination revealed weak peripheral pulses, distant heart sounds, and significant hepatomegaly. which is around 8 centimeters below the costal margin. So at this point, do the examination findings mentioned above change or support your thinking regarding the differential diagnosis or possible diagnosis? And what is your next step?
There is a question, Ali, was it a tender hepatomegaly?
Yes, it was a tender hepatomegaly.
Ilaf is answering it's myocarditis, heart failure.
Well done.
Safa is suggesting support, and Nazik is complicated heart failure, myocarditis with cardiogenic shock. Nazik is suggesting to do an echo. Karim ad-Din, what about the TFT ECG studies?
That's great. So in this child, the venous blood gas demonstrated metabolic acidosis with elevated lactate, and the child received further fluid resuscitation and started on inotropic support in the form of dopamine infusion, and broad-spectrum antibiotics were escalated from augmentin to ceftriaxone, gentamicin, and metronidazole, given the recent surgery and the deterioration and the possibility of sepsis as well. So, and at that time, the on-call consultant was informed and attended to review the child. And somebody was asking about performing an ECG, and this is the ECG of the patient here. Would you mind, please, to put in the chat what you think of the ECG and what is the abnormalities on the ECG?
We're getting few answers, Ali. Low voltage, electrical alternance, low voltage, pericardial effusion, and carditis.
Yeah, that sounds great. So the ECG shows there is low voltage, obviously, and there's sinus tachycardia, and there is like very concerning T-wave inversion in left precordial leads. If you notice at V3 to V4, there is T-wave inversion, and there is ST segment depression as well. So there is very this is absolutely abnormal ECG. So at this point, what could be the most likely diagnosis in a child who presented with a viral symptoms and abdominal pain with incirculatory shutdown, post-operative under general anesthesia, with hypotension and persistent tachycardia, and abnormal ECG and signs of heart failure? So I think the answer was mentioned. Some people, they answered it, but I think it is more clear now. The answer is going towards myocarditis. So a specialist advice was sought from the PICU and cardiology, and the child has improved from hemodynamic point of view. From blood pressure point of view, the blood pressure went up to 110/64 after 2 boluses of normal saline and on infusion of dopamine. However, the patient remained persistently tachycardic. That could be explained by the myocarditis or could be explained by the dopamine itself. Before transfer to the PICU, this child's COVID test came back negative. So at this stage in a child, the child clearly requires management in a pediatric intensive care setting, where advanced cardiovascular support and specialist cardiac assessment were available. So how would you transfer this child? Would you mind please share your thoughts on the chat box? How would you transfer this child to a tertiary unit to be admitted in a pediatric ICU? How would you transfer the child? And what team you consider this child to send with this child to the tertiary unit?
Mawadda is suggesting to get anesthetist and pediatrician.
Absolutely right. So this child was transferred with anesthetist and urgently via ambulance, and unfortunately this child was this happened out of hours, so it didn't happen during the working hours, so it was difficult. It was impossible to get a retrieval team, so it was transferred by the doctors, pediatricians and anesthetists from the same hospital. So in the PICU, a repeat ECG showed sinus tachycardia with low voltage complexes, T-wave inversion and right bundle branch block. The child unfortunately deteriorated further with oliguria and high lactate and worsening hypotension. Echocardiography was done and demonstrated severe biventricular dysfunction with stiff, poorly contracting left ventricle, dilated left atrium, and markedly reduced fraction shortening of 12%. And a diagnosis of severe fulminant myocarditis was done and cardiogenic shock. The patient was intubated, sedated and intubated and ventilated, and was sent to cath lab for balloon atrial septostomy to decompress the left atrium. Inotropic support was escalated to milrinone and norepinephrine, and the child received intravenous immunoglobulins and steroids. Despite maximum medical therapy, the child blood pressure was deteriorating and required to be put on veno-arterial ECMO support for 7 days. Extensive investigations failed to identify any causative organism. Viral PCRs, serology, and cultures were all negative. Autoimmune and connective tissue screen were also negative. The COVID test was repeated multiple times and thus was negative. Meanwhile, the acute kidney injury and liver function has improved to normal over the days, and the cardiac output and organ perfusion has improved. The PICU course of this child was complicated by raised compartment pressures in the left arm, and the child required left arm fasciotomy, and they found there was a very large extensive hematoma, and that was evacuated, and then that was followed by skin graft. As well, this child had a femoral artery injury that required repair, and that was all during the cannulation and arterial line placements. Despite these significant complications, the patient made a steady progress. After PICU stay of 17 days, the child was discharged to the ward and then home on heart failure medications, which was stopped after 1.5 years. Serial cardiac MRIs and studies remained normal with no evidence of fibrosis. And the child returned to normal physical activities without restriction and had no neurological, developmental, or cognitive deficits. This was an excellent outcome following an episode of life-threatening fulminant myocarditis. So the take-home message from this presentation is that persistent tachycardia is a major red flag. especially when it appears disproportionate to the clinical picture or persists despite treatment of fever or pain or dehydration or any other possible causes. Myocarditis is a great clinical mimicker and can present similarly to common pediatric illnesses. Abdominal pain, vomiting, and lethargy may be the presenting symptom of myocarditis, even in the absence of chest pain. Early investigations should include ECG, cardiac biomarkers, and echocardiography whenever myocarditis is suspected. Prompt recognition of myocarditis and escalation of care can be life-saving for such children. And specialist input is invaluable in managing these patients, in particular in the initial management in terms of starting medications and what choice of inotropes to use or vasopressors. Not all abdominal pain originates from abdominal pathology. Any child with persistent unexplained tachycardia and evidence of poor perfusion in a context of recent viral infection should prompt consideration of myocarditis and early senior review. Taking this case into consideration, I would like to get the thoughts of our colleagues in the platform here. What went well and what could have been done better in the management of this patient? With regard to the history taking, assessment, investigations, and appropriate assessment post-operatively, and timely seeking medical specialist review from tertiary hospital. I would kindly appreciate putting your answers in the chat box, please.
Dua was suggesting early ECG. Tasneem was telling for early involvement of pediatrics team. Muhammad was advising ECG and echo could have been done earlier and also intubated earlier. Safa is suggesting RBG. Is it rapid blood glucose? Not sure.
Yeah, that's valid. These are all valid points. Like the ECG is a must, like in a child with such presentation, to have an ECG to make sure that if there is circulatory, especially if there is tachycardia, then ECG should have been done earlier in such a child to see if there is any changes or ischemic changes or any other changes in the ECGs that could support the diagnosis of myocarditis. Early involvement of the pediatric team, that as well, that is a valid point. So such children need to be seen by senior pediatrician or senior whatever like level in the pediatric field. And it might not be possible to have echocardiography in peripheral hospitals, but at least ECG and well-structured approach in examination to pick signs of heart failure would be best. So if you mean by RBG, the blood glucose was normal for this child on the gas, and it was 5 point something on the gas. So I'm going to go for a very brief presentation for myocarditis in pediatrics. So myocarditis is inflammatory disease of the myocardium, and most commonly is of infectious origin, and it has a wide clinical spectrum of presentation. It can present subclinically and unrecognized, and which is the most common, and can present with acute heart failure and cardiogenic shock and arrhythmias and sudden death. The most common infectious cause for myocarditis is viral, and it is the leading cause in children. Other causes include autoimmune disease, toxins, and drug hypersensitivity. And it may be sporadic or epidemic. Common viruses, historically, the enteroviruses, especially Coxsackie-B, adenovirus, and parvovirus, Epstein-Barr virus, herpes human herpes virus 6 and 7, SARS-CoV, and multisystem inflammatory syndrome. Other causes include bacterial infections, which is rare, autoimmune illnesses like SLE, drug hypersensitivity reactions, and myocarditis can be associated with acute rheumatic fever, Lyme disease, and multisystem inflammatory syndrome, COVID-19. Myocarditis is rare, but that's more likely underestimated because most of it passes subclinically. So incidence of 1 to 2 per 100,000 children per year, and it has bimodal age distribution. It happens in infants and adolescents. 10 to 20% of sudden unexplained infants and children's death show myocarditis at autopsy. Usually the clinical presentation is following a recent viral prodrome within 2 weeks, and the symptoms can be non-specific, like vomiting, abdominal pain, respiratory symptoms, cardiac features including persistent tachycardia, out of proportion of fever, exercise intolerance, syncope, and myocarditis is frequently misdiagnosed initially. Severe fulminant myocarditis usually present with heart failure and rapid hemodynamic deterioration with features of hypotension, poor perfusion, hepatomegaly, acidosis, and arrhythmias are common, and this could be any type of arrhythmia. It could be supraventricular or ventricular arrhythmias, could be PVCs, PACs, and there is a high risk of sudden cardiac death. Diagnosis involves ECG, which can show sinus tachycardia, low voltage tracing, ST segment changes, prolonged PR interval, and heart block, T-wave inversion, prolonged QT, and arrhythmias. Can use as well, we can do troponins and PMPs. Chest X-ray can show cardiomegaly and pulmonary edema. Echocardiography shows ventricular dysfunction and dilated chambers. And cardiac MRI and biopsy, which is a gold standard, and that is rarely used. Thank you for attention and contribution to the discussion. Now I would like to hand you over to my colleague, Dr. Ibrahim Dafalla.
Thank you so much, Dr. Ali, for the excellent and thought-provoking presentation. I would like now to invite our panelist, Dr. Ibrahim Dafalla, consultant pediatrician at Cork University Hospital with a special interest in pediatric cardiology, to share his thoughts and reflection on this case. Thank you.
Thank you, Ala. Thank you very much. This is really very interesting case, and it was dealt with very nicely. And actually, like when Ali asked the question, what went well in that case, I think what went well is the approach for the child himself. Like when they call you that there is a child who is under the surgeon, he had appendicitis done and he has hypertension. He said it's not for me. This is maybe any something related to surgery. Like 3 hours after the surgery, the child has hypotension. This must be perforated bowel, must be bleeding, intra-abdominal bleed. This is not for me, this is for the surgeon. But the vigilance of the pediatric registrar on call, going there, examining the child and taking ABCD approach, examining everything like like examining the liver, the delayed capillary fill time, the blood pressure, the perfusion, the skin color, the level of consciousness, and listening to the heart, muffled heart sound. There is lots of hints that actually from start telling that this is not likely appendicitis, that were missed by the previous doctor. But I really admire the way the pediatric registrar approached that with vigilance and very well structured approach. So that in my mind went very well, and then also involving the seniors, transferring the child immediately and stabilizing with inotropic support. You know, when you are in a peripheral hospital with a child who has a cardiogenic shock, you will find very much resistant starting inotropes in a peripheral hospital. Most of them will say that they need a central line. The nurses are not familiar starting inotropic in the ward. Anesthetic, they will come, he's only 8 year old or 10 year. We didn't get it, there will be a delay in getting a central line, and it is time critical for these patients per se to get the line as quickly as possible, and or start or to have the courage and start inotropic support, because it is the answer here in this case. The blood pressure is low. They gave one bolus, 10 mil per kilo. The second bolus probably in my mind shouldn't be given, but it was given. So the answer was in the inotropic support, basically not the second bolus. What I want to present is like we did what you call we did a research in Kremlin Hospital about patients who were admitted with fulminant myocarditis requiring ICU admission. If you allow me, I will share my slide. Is that okay? So I'll try again. Is that clear to you?
Yeah, we
Can
can
you see my
see.
slide now?
Yes.
Yeah, we can see it very clearly, Dr. Ibrahim.
Yeah. So we did a research about outcome of Irish children admitted to PICU with severe myocarditis in the last 10 years in Children's Heart Center here in Ireland. I did with Martina Healy, which was one of the ICU intensivists here in Crumlin, and Professor Orloff Franklin, one of the senior pediatric cardiologists. So I must have some difficulty here. So but Ali spoke about myocarditis and how it present, how it is, and then our aim of this study is to describe the clinical and ICU course of children with myocarditis who were sufficiently unwell to require ICU level of care. So we therefore conducted a retrospective data review between 2012 and 2022 of all children admitted to intensive care unit with myocarditis, focusing on their demographic data, looking at ICU course in more detail. We looked at their ICU length of stay, um, and also what level of support they required, including requirement of invasive ventilation and the nature and the duration of the inotropic support, and also whether they needed ECMO, and also if they needed also dialysis. So we looked at the investigation that also these children had, and that include the cardiac function parameter, echo markers. We look in more detail at cardiac enzymes also, and also look at the degree of kidney and liver failure, end organ perfusion in general, and failure. So we also looked at brain image when that is done, and the wireless screening results. And we also looked at the outcome, what happened to them during their course, and at the end, the mortality and morbidity, and whether they needed heart transplant or not. So what we found during the last 10 years, a total of 22 patients were admitted to PICU with severe myocarditis, and the average age of 3 years. and these are equally distributed males and females, and the average weight is 11 kilograms. So when we looked at the marker of cardiac function, we looked at both the initial presenting cardiac markers and the worst cardiac markers. At presentation, the ejection fraction was 23%. So the normal level for children is 55%, and also the shortening, the fraction shortening, is another marker of the cardiac function. And what we found that they have a shortening fraction of 11%, and the normal is 25 to 44%. And this is actually consistent with severe myocardial dysfunction as per the American Society of Echocardiography definition. With regard to inotropic support, all children require some level of inotropic support, with 100% of these require milrinone. Milrinone is an inodilator. It improves the cardiac contractility without affecting the peripheral resistance as much. 80% require adrenaline, and then more than half required noradrenaline, and 10% of them require vasopressin. So in summary, all of them require inotropic support. Looking at the respiratory support, they need the provisional respiratory support is common, with 86% of patients require mechanical ventilation for an average of 10 days, and then 18% required further non-invasive ventilation for an average of 3 days. Additional support in form of ECLS, which is extracorporeal life support. And in that cases, in 40% of cases, inotropic support was insufficient enough to support the circulation. So 40% require ECLS, which is ECMO, and when that started, it needed to continue for 7 days. Half of these patients require balloon atrial septostomy in order to decompress the left atrium in the face of severe left ventricular function. And then just under one quarter of patients suffered acute kidney injury with renal failure, sufficiently severe to require hemodialysis. And when that is required, again, it was needed for an average of 7 days. Viral screening, we managed to isolate the viruses in 80% of these patients, and the 20% rest viral screening was negative. Cardiac enzyme, troponin, CK, and BMP in all these patients has abnormalities in cardiac enzyme, with an average value of cardiac troponin 1,200, and creatinine kinase 1,500, and BMP 3,800. With regard to outcome, with this intervention, 14 patients has recovered their cardiac function and were discharged alive from the PICU. One patient need temporarily left ventricular assist device. The remaining 7%, 4 of them needed heart transplant, and 3 patients were unfortunately died. So here in the outcome, like 32%, which is 1/3, either dead or require heart transplant, which is mean that it is very high mortality. So in conclusion, myocarditis in children is a serious disease with high morbidity and mortality. As such, high index of suspicion is required for diagnosis, and early referral to PICU is necessary also to improve the outcome. Thank you very much, and we're happy to take questions.
Before we move to the questions, we are honored tonight to have Professor Sati with us this evening. Given his extensive experience and expertise in pediatrics, I would like to invite him to comment on the case and share any observations or learning point from the case with the audience. Professor Sati, the floor is yours.
Professor Sati, you are mute.
So we can move to the question and discussions for now until Professor Safi join us. I would like kindly to ask everyone to take few moments to fill the feedback form while we are waiting for the questions. Please share your questions in the question and answer box.
There is a question from Dr. Huzaifa El-Hidayi, and the question says, was there any atrial septal stent put, or was it only septostomy? Actually, this patient was transferred to a tertiary unit, PICU, but I had the chance to go and see through the procedure, so it was septostomy, balloon atrial septostomy. There was no mention of a stent on the operation. Although this is out of the scope of my practice, but maybe Ibrahim would be the best person to comment on this.
Yeah, so they only did septostomy, and septostomy alone was enough, and they usually create adequate atrial communication to decompress the left ventricle and improve the cardiac output. They didn't did septostomy stent.
Asma is asking why bradycardia in this case.
Bradycardia in that case, as you know, myocarditis can cause heart block, so it could be secondary to heart block. Although it's difficult to say without having that as an evidence, as a telemetry or what you have during the. But it could you could have expected that with the child has a complete heart block. You could have tachycardia.
Ilaf is asking two questions. First, does ST depression is part of myocarditis?
Ali, will you please share the ECG again? I want to comment on that actually, as it's
Yeah,
part of my.
absolutely.
Like I thought of that to mention because there is many finding in the ECG that wasn't commented on before. So, if you don't mind, Ali, if you can share the ECG
Yeah,
of
absolutely.
that patient.
And meanwhile, what is the meaning of shortening fraction, Dr. Ibrahim?
The shortening fraction is one of the echo calculation. When you calculate the ejection fraction during the echo, you do an M mode, and the M mode it measures the during contraction. You see if the heart is pumping well, you see the heart is moving, but if there is moving in and out. So the degree of these two like left ventricle wall coming together reflects the pump, how powerful is the pump. When you have myocarditis and all the myocardium is inflamed, the contractility will be very short. The heart itself will be very weak too. So the shortening, you see how like the degree of these walls coming together, you take that the machine count that as a percentage, and the normal this should be like 25 to 40%, but in these patients it's only like 11%. So this means that the degree of the pumping function, or like pumping capacity or efficiency of the left ventricle is decreased, because it was shortening, or like it wasn't pumping enough. So it's machine derived measurement. It's difficult to explain without showing that in video, but I hope I just make it clearer to you that just it is a measurement. The machine measure how efficiently the left ventricle is pumping. The ECG, yeah. So the ECG, the left. Can you see my markers? Ali, if you see if you point to the V5, V6, the T wave.
Yeah,
So
okay.
the T wave in V4, V5, V6 is inverted here, and
Yeah.
this is a marker of left ventricular. This is a marker of left ventricular strain, or like pressure overload. And this is abnormal, and this happened in myocarditis. It happened also in cardiomyopathy. In cardiomyopathy, if it is like hypertrophic cardiomyopathy, you will see the R wave is very tall, because you expect that the left ventricle is muscle is thick, so you have LVH. In HOCM you will have LVH and left ventricular strain in a form of T wave inversion, ST depression. But when you have T wave inversion and you have low voltage, you should put myocarditis at higher, one of your higher like at first, it will be should be your first differential diagnosis. The other also abnormal, you can see also in V1, V2, V3. Also, the T wave is upright here. At this age, this child is I think it's 8 or 10-year-old. But in fact, uh, the ECG before puberty, the T wave in all children in V1, V2, and V3 should be inverted T wave. When you have that is not inverted, it's upright, this is a marker of right ventricular strain, and it also can be seen with pulmonary hypertension also. So when you see it's upright, it is abnormal. Although the T wave is upright here in V1, V2, V3, it is abnormal. It is not normal for this age. And you also see the low voltage.
Sorry.
There is one before he said Al-Kaaba. Al-Kaaba also share similar finding, ECG finding, but more toward Al-Kaaba, you will see deep Q wave in lead AVL, which is very specific for Al-Kaaba. Al-Kaaba is when you have Al-Kaaba stand for anomalous left coronary artery from pulmonary artery, and that's congenital anomaly. It usually appear in the first few months of life. The first few weeks usually is not they are asymptomatic usually in the first few days to few weeks, but by 2-3 months they will have severe ischemia enough to result in left ventricular dilatation, strain, and you will have the Q wave as an evidence of ischemia. So that's another marker of and at the same like myocarditis, Al-Kaaba, and cardiomyopathy, they share the same clinical finding on the ECG, same finding on the ECG basically. But as I said, in cardiomyopathy you may see tall R wave. In Al-Kaaba you'll see Q wave in lead AVL.
We have a question from Hanan. She's asking, in pediatric ED, how she can suspect viral myocarditis and admit the patient accordingly. What are the criteria?
That's a very good question. Actually, there is no special criteria, but I think you go with your careful history and examination. So a structural examination and assessment of the vital signs, and revisiting the examination and vital signs every now and then if you think the child diagnosis or condition is not going the right direction. So based on the history, then viral symptoms on vital signs, persistently tachycardic child. If a child has a viral infection with fever, with control of fever, you expect the heart rate to come down to normal. So, but if still after control of fever and control of pain, the heart rate is still persistently high, then you need to, that rings a bell. It could be like many different diagnosis, but it is a red flag. Like if you have a tachycardia, it could be sepsis, could be other, could be any other cause of that, bleeding somewhere. So it is there is no clear like guideline. Maybe if there is, but the history examination, vital signs, careful structural approach in examination. Like this child, pretty sure the liver was enlarged at the time of the first presentation. So, but because it was very enlarged and the capsule is causing the pain, if you touch the child in anywhere in the tummy, then the child would say pain, would feel pain. So, but careful examination would have picked hepatomegaly. And the hepatomegaly, if was picked earlier, then that would have changed the thought process of the clinician who examined the child in the first place. So careful history examination, assessment of vital signs, and revisiting the vital signs and examination, and seeking a senior colleague advice and review of the patient would make a difference in such case presentation.
We have a question from Dua about the fluid bolus. What fluid bolus volume would you consider safe to administer initially, especially in the peripheral center, whereas you mentioned the reluctance to start inotropes?
Thank you, Dua, for the difficult question. The cardiogenic shock in APLS, they usually advise to start 5 to 10 mil per kilogram. And also now the ED team are usually using ultrasound approach also. They also in this patient, usually when they are suspecting that this is not this is a cardiogenic shock, they do a point of care ultrasound to see the contractility of the heart, and if they feel that the heart is not pumping enough, they could be more rationalized in giving fluid. And also they can see the inferior vena cava on the abdominal ultrasound and see it will give you the how distant is the inferior vena cava, and it can tell you about the intravenous or intravascular volume, and is that responding to uh, with breathing or not. So I know this is not part of the APLS, but many pediatric ED team are using after the first bolus. They use a ultrasound probe to just to check the contractility and to check for the inferior vena cava distensibility.
Another question from Asma about the need to involve immunology or consult them.
In this case, I don't see directly a need to involve immunology at this point for a child with a cardiogenic shock. However, immune globulin has a role in cardio, in myocarditis, and now in many centers they use it. Now, although there's some still controversy about how the way they are proving things or how effective are they. But they use immune globulin, but I don't think there was a direct need for immunology in early involvement of these cases.
Alan is still asking about the persistent tachycardia indication for admission to admit the patient for ECG and call the pediatric cardiology early in pediatric ER, other than to discharge the patient home, and then he will come severely ill and shocked.
Yeah, absolutely. As we just mentioned, yeah. So persistent tachycardia should be taken seriously. So you're right. So I think some hospitals might have some guidelines if there is suspicion of myocarditis. I think that probably in the UK, if there is myocarditis, then what to do next, or suspicion of myocarditis, what to do next, and how to escalate the patient. So, but if the ECG findings showing signs of, if the child clinically is showing signs of myocarditis, and the ECG findings myocarditis, X-ray findings, troponins, and PMB depends on the availability on your hospital. So depends on all these collectively, then you can come with the conclusion with highly suspicion of myocarditis, and then go ahead according to. There's no, many hospitals, they don't have guidelines for that, but some hospital might have it. So what we can say that you need to have a high index of suspicion for the myocarditis, and if you think there is myocarditis, then that need to be taken seriously.
There is a question about the role of IVIG without ECMO or intubation to improve the outcome.
Yeah, as I said, the role of IV immunoglobulin is controversial, but I think many centers still use it because in this patient, like if you are waiting for, you try to do everything that could help the patient because they can deteriorate very quickly, and the ECMO itself is not available in every center, so they can use it to buy time till the patient reach the tertiary center. Usually, in fact, actually, they started in the ICU after the patient arrives there. You have the diagnosis confirmed, seen by cardiology. They agree on the diagnosis, and then they take the initial number for echo and cardiac function, cardiac markers, and then they start with the inotropic support, diuretics, and then also IV immunoglobulin. But it is still controversial. No, it's not. It's not part of the full protocol of myocarditis.
Dr. Karimuddin is commenting about the functional abdominal pain, which might arise outside the abdomen.
Sorry, again, I didn't hear that.
Dr. Karimuddin is just commenting on the functional abdominal pain, which may arise outside the abdomen or in relation to our case.
Yeah, the acuity of this patient scenario is like yes, you might consider functional abdominal pain is one of your differential also, but the acuity when the patient come for short history, you still have this in mind, but it will be a little bit less lower in your differential diagnosis. Professor Sati is raising his hand now. Ala, if you're
Yes, Professor Sati, it's my pleasure to invite
طيب
Professor
السلام
Sati to share his comments.
Thank you, Dr. Ali and Dr. Ibrahim, for this really well organized, very useful presentation on this topic of myocarditis as one of important causes of abdominal pain in children.
جزاك الله خير دكتور سعد، شكرا جزيلا يا أخ، بارك الله فيك. الصوت قطع ولا خلص الكلام ولا؟
How common is acute appendicitis and acute pancreatitis as one of the important causes of abdominal pain in children, either in our country or internationally? Is it still an important causes of abdominal pain acutely or not not important.
Yes, abdominal acute appendicitis. Yes, it's very common, really. I was working in Librick Hospital, and every day we have a pediatric ward. I think 24 patient. At least every day we have 2 or 3 bed for children admitted with appendicitis or suspected appendicitis every day morning. So it's definitely very common. However, the diagnosis now, I think the surgeon can answer that better, but most of they need ultrasound before intervention in general. It's not like us back home. If you in doubt, take it out. Which result in lots of taking doing appendectomy. But it definitely is it's very common cause of abdominal pain here in Ireland for sure.
طيب, I have a comment, if you don't mind.
Yes, please.
Yes, تفضل يا دكتور طه.
Ireland Group, thank you very much. Wallahi, this was very nice, very focused, and I think you just did exactly what we need to do in any morbidity cases. You went through the case, honestly, what went, how it went from the start, and like step by step, and eventually, after you presented the case, you discussed what happened, and what went well, and what could have been done differently. Dr. Ibrahim commented on the myocarditis itself, so and gave more details. And the research or the audit that they did, which was very nice. I just want to say congratulations. This is well organized, and it's very, very interesting, very important to have trainees with us as well. Ali did a nice job, and I take the chance to invite other trainees as well, not to be afraid of coming. It's nice. Now it will be like a presentation in an international meeting, which is very good in your CV. Once again, thank you very much. Despite the short notice, you did a very good job with Ala as well as the moderator. Thank you both, guys.
Dr. Ala, we have Dr. Yasir Jabra, is intensivist, and Dr. Bahauddin from Sudan and Qatar, respectively. They are raising their hand. We'll just ask them to open their mics, Dr. Baha and Dr. Yasir.
السلام عليكم.
عليكم السلام دكتور ياسر، كيف اخبارك؟
كيف؟ ان شاء الله
ان شاء
بخير.
الله طيب يا
شكرا.
رب يصحتك.
الحمد لله. شكرا دكتور ابراهيم, Dr. Ali, for this very nice presentation. And it is very challenging to diagnose myocarditis and very hard. Yeah, I did my fellowship. My research in fellowship was on myocarditis and dilated cardiomyopathy in children less than 2 years. So it is so hard. We did a retrospective study, and it took for many of these patients long time to be diagnosed. You see, they come after 2-3 visits to be diagnosed. But when they come at that time, they usually come in heart failure. So, and it is very hard. Some of them, they have X-ray. If you did X-ray, some of them, my patient, 100% of them, they have cardiomegaly, and 100 of them, they have abnormal ECG, and 1/3 of them, they have abnormal blood gas. With what we found, they have this combination of metabolic acidosis and respiratory alkalosis. Usually, when I see this combination on a blood gas, this is usually this child has a very bad condition. So it is very challenging to diagnose. And the other thing which we found very significant is the tachycardia, which was on your patient. So if you have any persistent tachycardia, this is very worrying. You have to search why this child is still tachycardic. And some of them, even they don't have fever and they have resting tachycardia, which was very worrying. And they have this abnormal ECG, usually, as you said, Ibrahim, V5, V6. If you have inverted T wave, this is very concerning. Yeah, so it is very difficult. Here in Sudan, we saw, I don't think we saw so many patients, but they have myocarditis. Some of them, they recovered. We gave them immunoglobulin. Others, they have 2 patients, they have persistent arrhythmia. And you know, if you have persistent arrhythmia, you need ECMO, which we don't have, unfortunately. This child has, like, we gave him up to amiodarone, doesn't respond, and unfortunately he died because he needs higher care, which is not available here. But I think it needs very high index of suspicion to diagnose myocarditis. If you have someone who is not improving after you gave your initial treatment, you have to do reassessment, thorough clinical examination, and thorough history. Thank you very much for raising this awareness, and people all the time keep this unusual diagnosis on your hand. And here, even in Sudan, we start to use this point of care ultrasound. If we give any bolus, if the child is not doing well, we just do the ultrasound and you see the heart is not pumping very well. That means, okay, this is something else. This is most likely myocarditis. Thank you very much, the Irish team.
شكرا ياسر يا اخي، والله جزاك الله خير يا
شكراً
اخي.
جزيلاً.
Thank you,
والناس
Dr.
كلهم هنا
Yasir.
في ايرلندا بيسالوا منك يا اخي، والله صراحه.
لا ايرلندا دي ما بلدنا، قضينا فيها اجمل زمن، يعني من اجمل البلاد، يعني بلد
يا
جميله،
سلام.
بلد جميله جدا جدا،
يا
عندنا فيها
سلام.
ذكريات فيري نايس.
الله
Thank you
يديك
so much,
العافيه يا
Dr.
اخي.
Yasir. Dr. Bahadin, please join us.
Okay, thank you very much, actually, Dr. Ibrahim and Dr. Dafalla, for these very nice presentations. Actually, as the night mayor of diagnosis of myocarditis, and let me add also when we say myocardial dysfunctions associated with sepsis, you know, sometimes the terminology when you face as intensivist with the cardiologist is a little bit dilemma. But at the end, as clearly mentioned by Dr. Ibrahim here, you need to approach the child by history, examination, and assessment, and how to monitor him in proper way, actually. Because either which the term is came as a myocardial dysfunction, it is towards the myocarditis and towards pericarditis or towards severe cardiogenic shock, you need to know the step-wise how to treat the patient in a time-based wise. And recently, I have very one child, who's 7 weeks old, with very invasive pseudomonas infections. The IDs came as a shock patients with lactate is very high, low urine output, and there is no that obvious cardiomegaly is there. However, within less than 24 hours, he became very overt picture of myocarditis. As we say, usually we cannot say by a spot diagnosis rather than just professional diagnosis on background of history he came with. Very complicated with pericardial effusion. Pericardial effusion drainage have been done, catheter inserted. This came also positive with the same, and he have multiple organ failure now. And this patient. The point is, I just go back to what last time you comment on, Dr. Ibrahim, about or Dafalla, about the use of inotropes in the when it is needed or when it is dedicated. Actually, especially we speak about our colleague in Sudan here. A lot of questions about use of fluid boluses, especially in low setup resources. If Yasser agree with me, and hopefully now with this revolution with Jebra and others, and changing the practice to a bed condition, rather we will not speak about advanced. But however, we need to think about how safe the children in Sudan also, especially in such a cases is there. With background and other multifactorial factors there may make them at a risk when we give an improper fluid boluses. Just to highlight, I don't want to take a long time, about the use of inotropes when it is indicated, It is in time manners, and what type of inotropes I needed, and how to use it actually. Peripheral line now, in most of the standards guidelines, it is there, because as early as it started, it's more or less harmful than they use too much fluid unnecessary there. How to use it? there is the same circumstances that you need to how to use it in peripheral lines, not become randomly to use it where. Especially if I start in the low dose of pressors, it will be more safe and effective if I use it in new IV line, and I should select a very large vein, and I should continuously monitoring for any extravasation of these anatropes around the line which I use it. So you can put anatropes in a peripheral line if you are know how to put it where and how to monitor it is there. Because early is more safer than giving of too much fluid rather than just an oxygen. The patient, because simple bolus of fluid wrong, it can went to an ventilation, and we have many cases. This is a big topic to open it, but thank you again very much for highlighting this topic, especially to our colleague in Sudan. I hope maybe we revisit this topic in a different way again. Thank you very much.
جزاك الله خير يا بهادين يا أخي، جزاك الله خير، شكرا جزيلا على الكلام الجميل والطيب، بارك الله فيك. Yes, definitely. Yeah, I remember we have one patient also with myocarditis, and he was a big boy. He think he's 13-year-old boy, but he came in very bad shape with very poor peripheral perfusion. His skin is very mottled. Capillary fill time is 5 seconds and more, and cold skin. And then the nurses in the ward, they have a rule not to start inotropic support in the ward. He is on the way to ICU. We spoke to ICU to take him, but I insisted for them to start the inotrope, and I told them the ICU is on the way. He is not staying here. Just we need to start because now it is time. Otherwise, the patient may get worse. And in fact, shortly after the patient arrived in ICU, a few hours later, he was in ECMO. So yeah, when it's time to inotrope, it should be started as soon as possible.
I think as Baha said, sorry to recommend again. Yeah. So as Baha said, I think we revisit this inotropic support in a different session. Yeah, because it is commonly used here in Sudan. I think people, because nurses, they will not object like when you are outside. If it is not peripheral IV, they will not give it. But here people use it. They use it very widely around the country because there is no other option. So if you wait, the child will die. So they use it. So I think we'll revisit it in another webinar, inshallah.
That will be great. Yes, really, it's very important topic, definitely for sure.
While we're waiting for the last comment or question, I would like to remind everyone to take a few minutes to complete the feedback form. And also, this session has been recorded, and the recording, along with the previous meeting and presentation, will be available on the International Sudanese Academic Pediatrician Platform YouTube channel.
While we're waiting for the any questions, so I just would like to highlight as well, there is a point mentioned by Dr. Karim Ad-Din. So yeah, so we mentioned the abdominal pain, that abdominal pain is a cause that is in the chest. I think we went anatomically upwards. So if there is abdominal pain, I think we should rule out as well if there is any pathology on the chest or in the perineum and pelvis. So take the abdominal pain seriously itself and work out what is the diagnosis in the abdomen, and don't forget the other sites that could be the culprit for the cause of the abdominal pain. Could be from the chest, pneumonia, myocarditis, could be in the perineum and the pelvis, and like testicular torsion can present as abdominal pain. So examining the chest and pelvis and perineum for serious causes of abdominal pain should be one of the very things that need to be checked.
Dr. Ala,
Yes.
any other questions or comments in the chats or any?
Nothing on the chat box, nothing on the question and answers. Well, I think we are, yeah.
Okay, you can proceed for your closing remarks.
So, thank you to our speaker, Dr.Ali Eltoum, our panelist, Dr. Ibrahim Dafalla, and all the participants for joining us this evening. We greatly appreciate your time, engagement, and contribution to the discussion. We look forward to seeing you on our next meeting. Thank you, everyone, and have a wonderful evening.
ثانك يو آلاء، جزاكم الله خير. شكرا جزيلا طه، شكرا كل البانليست، شكرا ياسر، جبرة، بهاء الدين.
شكرا لكم.